Hello everyone. Today let's delve into Kiloh-Nevin syndrome, also known as anterior introitious nerve entrapment syndrome. We'll start with the anatomy. The anterior introitious nerve is a branch of the median nerve, typically arising 2 to 6 centimeters below the level of the medial epicondyle, as shown in the figure. Due to its inconsistent origin, a range is provided. In most cases, it arises from the posterior fascicles of the median nerve, as shown in the figure, although there may be variations in some individuals. Here is an variant wherein the nerve arises posterior-medially and more distally, passing beneath the flexor digitorum superficialis. Anterior introitious nerve is usually accompanied by anterior introitious nerve and vein, that is anterior introitious vessels. The anterior introitious nerve supplies radial half of flexor digitorum profundus, flexor pollicis longus and pronator quadratus. Etiology includes compression of the nerve by the fibrous bands or arcuate ligament of the deep head of the pronator teres or by flexor digitorum superficialis, thrombosis of the anterior introitious nerve vessels, compression of the nerve as a result of supracondylar fractures, direct trauma or penetrating wounds secondary to the fractures, usually the proximal third of the forearm fractures. Others include weightlifting, external compression due to castings or injections in the form of steroids or forearm crutches. Gamzer muscle is an accessory muscle in the forearm that's part of flexor compartment. It's an anatomical variant seen in 50 to 68% of the forearms. Can cause AIN entrapment syndrome. Since the anterior introitious nerve is primarily a motor branch, sensory symptoms such as tingling, numbness are less commonly observed. Instead, patients typically experience motor deficits such as weakness or atrophy in the muscle it innervates. Clinical findings include pinch test, Benedict test, modified Mills test, and weak supination. Benedict sign and also the pinch test will be positive mainly because of the weak flexors, that are flexor pollicis longus and the radial half of the flexor digitorum profundus. A small demo between normal and anterior introitious nerve affected patients. So here is how it looks. Treatment includes conservative or surgical management. Conservative management includes casting the limb in supination for relieving the pressure symptoms, or nerve blocks with local anesthetics or steroids. The surgical intervention should be considered if these conservative management fail for at least 8 to 12 weeks. Surgical management involves the release of the anterior introitious nerve and its compressing structures such as laceratus fibrosis, adhesions of the median nerve, or bicipital aponeurosis. Incision will be an X-shaped incision with the horizontal component being the elbow flexion crease.